All right, welcome back everybody to the deep dive. We're going deep today on, well, cardiology.
Yes, cardiac pathophysiology.
Yeah.
A little bit of a mouthful.
It is, but it's so important for nurses. It's the core of providing, really excellent nursing care. We're going to be referencing cardiac pathophysiology for nursing students.
That's right. And this is one of those deep dives that we really wanted to do.
Yeah, we get a lot of requests for cardiology.
Oh, yeah.
It can be kind of tricky, and this particular book is really good.
Yeah, really well written.
Yeah. So we're going to be talking about ischemic heart disease, IHD,
Yep.
heart failure, HF, different cardiomyopathies, arrhythmias,
Valvular heart disease.
inflammatory processes,
Genital heart defects in adults.
and shock. And when we talk about shock, we're mostly going to be focused on cardiogenic shock.
That's right.
But I think a good place to start is, just a good foundational understanding of the anatomy and physiology of the heart before we jump into the pathophysiology.
Absolutely. You have to know how it's built and how it works.
Right.
To understand what happens when it goes wrong.
Exactly. So let's start with the heart wall.
Hey, what?
Kind of picture a three-layered cake, right?
Okay.
So the inner layer, the, frosting closest to the actual cake, would be the endocardium.
Right.
And the endocardium is that smooth lining on the inside of the heart. But right underneath the endocardium is the subendocardial layer.
Yes.
And that's where we find a lot of the electrical system components, like the Purkinje fibers.
That's right.
And the subendocardial layer is also particularly vulnerable to ischemia.
Right.
Or lack of oxygen.
Yeah, that makes sense. It's the furthest away from the blood supply.
Right.
Which comes from the coronary arteries on the outside of the heart.
Exactly.
So it gets hit first.
Yeah, and actually when people have endocarditis, that infection is usually in the subendocardial layer.
Interesting.
Yeah. Okay, so so now we're in the actual cake of this cake, right? That's the myocardium.
Okay, the heart muscle itself.
The heart muscle. The myocardium is made up of cardiomyocytes, which are like packed full of mitochondria.
The powerhouses of the cell.
The powerhouses of the cell, yes. And those cells, the cardiomyocytes, they're all connected to each other through these things called intercalated discs.
Right, and those discs allow the heart to function as a single unit, right?
Yeah.
So it's not just a bunch of individual cells contracting randomly.
Right. It's like a syncytium.
That's right.
All working together.
Like a synchronized swimming team.
Yes. A synchronized swimming team.
Uh.
And it's important to remember, too, that the thickness of the myocardium varies depending on the chamber.
Right. The left ventricle, which has to pump blood to the whole body, is much thicker
Yeah.
than the right ventricle, which only pumps blood to the lungs.
Right. And when the myocardium gets damaged, like, say, after an MI,
Myocardial infarction.
a heart attack,
Yeah.
it heals by forming a scar.
Right.
But scar tissue doesn't contract as well.
No, it doesn't. And that can lead to all sorts of problems,
It can.
which we'll talk about later.
Yeah, we'll get there. Okay, and then the outermost layer of the heart is the epicardium. And the epicardium is actually the same as the visceral layer of the serous pericardium. It's just two different names for the same thing.
Okay.
And that's where the coronary arteries live, which supply blood to the heart muscle itself.
Right. And the nerves that innervate the heart.
Yes. And then we have the heart chambers, which I think most people are pretty familiar with.
Right. 2 atria and 2 ventricles.
Right. The atria are those thinner-walled upper chambers.
They're like receiving chambers.
Yeah. And then we have the ventricles. The ventricles are the real pumping chambers.
The workhorses.
Yeah.
And don't forget about the atrial kick.
Oh, the atrial kick. Yes, that final contraction of the atria.
Right before the ventricles contract.
It can really help top off the ventricles.
Yeah. Especially when the heart rate's up.
Especially when the heart rate's up or if the ventricles aren't as flexible as they should be. And inside the ventricles, you've got all those like ridges.
The trabeculae carni.
Yes, trabeculae carni, and then the papillary muscles.
With their chordae tendineae.
Yes, those are so important.
Oh, absolutely. They're like little anchors for the valves.
Right. They keep the valves from flapping backwards.
Right. Imagine trying to hold a kite in a strong wind.
Yeah.
Those papillary muscles and the chordae tendineae are like the strings, keeping those valve leaflets in place.
Love that. Okay, now for those valves.
The gatekeepers of blood flow.
Yes. We've got the atrioventricular valves, or EV valves.
Tricuspid on the right, mitral on the left.
Right. And when they close, we hear that first heart sound, lub.
S1.
Then we have the semilunar valves, the pulmonic and aortic.
And they close to give us S2, the dub.
Yes. And it's worth mentioning that those valves are actually made up of different layers.
Yeah, they're not just simple flaps.
No.
They're designed to withstand a lot of pressure
Right.
and make sure blood flows in the right direction.
Precisely. And understanding those valve sounds is so important when you're auscultating the heart.
Absolutely. Like if you hear a murmur,
Yeah.
it can tell you which valve is affected.
Yeah, the timing of the murmur is key.
Right. And it's systolic between S1 and S2,
Hmm.
or diastolic between S2 and S1.
Exactly. Okay, now let's talk about the heart's own personal blood supply, the coronary circulation.
Right. The heart needs oxygen too, right?
It does. It works really hard. The right coronary artery, or RCA, that comes off the aorta,
Right.
and it wraps around the right side of the heart.
Supplying blood to the right atrium, right ventricle.
Usually the SA node, which is the heart's natural pacemaker.
Right. And usually the AV node too.
Yeah, the AV node as well.
But not always.
No. So, you might hear people talk about coronary dominance.
Yeah, that can be confusing.
It is. It basically refers to which coronary artery, the RCA, or the left circumflex, supplies the posterior descending artery, which we call the PDA.
Right.
And most people are right dominant.
Meaning the RCA supplies the PDA.
Exactly. But some people are left dominant.
Meaning the left circumflex supplies the PDA.
Right. And that can be important clinically.
Oh, absolutely. Like if someone has a blockage in their dominant artery,
Right.
the consequences can be more severe.
Right. And if that blockage affects the AV node, you can have some serious conduction problems.
Right, like AV blocks.
Exactly. Okay, let's move over to the left side of the heart.
Okay.
The left coronary artery, or LCA, it's usually a little shorter than the RCA, and it branches off into two main arteries.
The left anterior descending artery, or LAD.
Yes, the LAD, and then the left circumflex artery, or LCX.
Right.
The LAD, sometimes it's called the widowmaker.
Yeah, for a reason.
For a reason.
It supplies a large portion of the left ventricle,
Right.
which is the main pumping chamber.
So it supplies the anterior wall, the septum, and the apex.
Right.
The LCX curves around to the back of the heart.
Supplying the lateral and posterior walls of the left ventricle.
And sometimes the SA and AV nodes, too.
Right, depending on dominance.
Depending on dominance, exactly. And this is where it gets really interesting when we talk about ECGs.
Absolutely. ECG interpretation.
Yeah. So, if you see certain changes in the anterior leads, it often means there's an issue with the LAD.
Right.
So, knowing the anatomy of the coronary arteries really helps you pinpoint where the problem might be.
Yeah, it's like having a map of the heart's electrical system.
It is. And then, of course, we have the veins. We can't forget about the veins, taking the blood away from the heart muscle.
The coronary veins.
Yeah, most of them drain into the coronary sinus, which then empties into the right atrium.
Right.
We also have these smaller veins called the Thebesian veins, and they actually drain directly into all four chambers.
Interesting. Oh, right. Okay, last but not least, the pericardium.
That fibrous sac that surrounds the heart.
It's got two layers, the fibrous pericardium.
Which is tough and protective.
Yeah. And the serous pericardium.
Which has two layers of its own.
Yes, a visceral layer and a parietal layer. And in between those two layers is the pericardial space, with a little bit of fluid for lubrication.
Right. And the pericardium does some really important things. It anchors the heart in place.
Prevents it from overfilling.
Provides protection and reduces friction.
Right.
And don't forget the nerve supply to the pericardium.
A phrenic nerve.
Yes. That's why sometimes when people have pericarditis, they have pain in their shoulder.
Referred pain.
Yes, referred pain. Okay, let's move on to the heart's electrical system.
The conduction pathway.
The conduction pathway. This is what makes the heart beat rhythmically. It all starts with the SA node.
The sinoatrial node.
Yeah.
The heart's natural pacemaker.
Yes. It's located in the right atrium, and it spontaneously generates electrical impulses.
Setting the heart rate.
Right. Those impulses spread quickly throughout the atria, causing them to contract.
And then the signal reaches the AV node.
The atrioventricular node.
The gatekeeper.
Yes, the gatekeeper. It's located in the interatrial septum near the opening of the coronary sinus.
Right. And it has this really important job.
Yeah.
It slows down the electrical impulse.
Right.
Just for a split second.
Yeah.
But that delay is crucial.
It is.
It gives the atria time to fully empty.
Into the ventricles.
Right, before the ventricles contract.
Exactly. So after that pause, the signal speeds up again, traveling down the bundle of His.
Which divides into the right and left bundle branches.
Right.
And then spreads throughout the ventricles via the Purkinje fibers.
Causing that synchronized ventricular contraction. And the speed of conduction varies, at different points in this pathway.
Right. The AV node is the slowpoke.
It is.
And the Purkinje fibers are like the Autobahn.
Yes, the Autobahn. Love that. And those pacemaker cells in the SA and AV nodes, they have this special ability.
Automaticity.
Automaticity, yes. They can generate their own electrical impulses.
They don't need an external signal.
Right, and that's because of their unstable resting membrane potential, sometimes called the funny current.
Right.
And the SA node is the boss, right?
Yeah. Right. It sets the pace because its cells have the fastest inherent firing rate.
Exactly. Now, the autonomic nervous system can influence the heart rate too, right?
Oh, absolutely. The sympathetic nervous system speeds things up.
Like when you're stressed or exercising.
Well, it's the fight or flight response.
Yeah,
And
yeah.
it does that through beta-adrenergic receptors.
Right.
And then the parasympathetic nervous system slows things down.
Right, like when you're resting.
Right. And it does that through muscarinic receptors.
And it's interesting, at rest, the parasympathetic system kind of has the upper hand.
Yeah, keeping things calm.
Keeping things calm, yes. But if something goes wrong with the electrical system, you can get arrhythmias.
Right. Like if the RCA gets blocked
Yeah,
and it's supplying the AV node, you can get an AV block.
yeah. And that can really mess up the coordination between the atria and the ventricles.
Absolutely.
Or if the SA node itself malfunctions, like in sick sinus syndrome.
Right. You can see a whole range of abnormal rhythms,
Yeah,
and these arrhythmias can really impact cardiac output.
right. Leading to symptoms like dizziness, fatigue.
Even syncope,
Yeah.
fainting.
Okay, so we've covered the structure and the electrical system.
Right.
Let's talk about the mechanics.
The cardiac cycle.
The cardiac cycle. So this is like what's happening with every single heartbeat.
The sequence of
A
events.
sequence of events. And it's divided into two main phases. Diastole and systole.
Diastole is the relaxation phase,
The filling phase. And systole is the contraction phase.
the pumping phase.
Yeah.
So let's start with diastole.
Okay.
First, we have isovolumetric relaxation.
Isovolumetric relaxation.
It's a mouthful.
It is a mouthful, but it makes sense if you break it down.
Right. Iso means same,
Volumetric refers to volume.
and relaxation means the ventricles are relaxing.
So the volume of blood in the ventricles stays the same,
Right.
but the pressure inside the ventricles is dropping rapidly.
Because they're relaxing.
Right. And during this phase, all four valves are closed. Yes, briefly. And then, as the pressure in the ventricles drops below the pressure in the atria, the AV valves open.
The mitral and the tricuspid.
Yeah.
And blood rushes into the ventricles.
Right. This is rapid ventricular filling.
And you might hear an S3 heart sound here.
Yes. Especially in kids.
Or adults with heart failure.
Yeah. Or fluid overload.
Right. Then the filling slows down a bit.
Right. That's reduced filling or diastasis.
Right. And then comes the atrial kick,
The atrial kick.
the atria contract,
Right.
giving that last bit of blood to the ventricles.
Right.
And that's about 20 to 30%
Yeah.
of the ventricular filling volume.
It's a good kick.
It is.
And on the ECG, that corresponds to the P wave,
Right. And if you hear an S4 heart sound, it's happening right here.
just before S1.
Yeah. And it can indicate a stiff ventricle.
Right. Like in hypertrophy.
Right.
Okay, so now the ventricles are full.
End of diastole.
End of diastole. The volume of blood in the ventricle at this point is called the end diastolic volume.
Or EDV,
EDV.
preload.
Preload, yeah. Okay, now ready for systole.
Systole, the ventricles contract.
It starts with isovolumetric contraction.
Another mouthful.
I know, right? Again, same volume.
But this time the pressure is rising rapidly.
Because the ventricles are contracting,
Right.
all four valves are closed again, briefly.
And then, when the pressure in the ventricles exceeds the pressure in the aorta and pulmonary artery,
Oh, the semilunar valves open.
the aortic and pulmonic valves,
Yes.
and blood is ejected.
This is ventricular ejection.
Right.
And the volume of blood ejected with each beat is called the stroke volume,
Or SV,
SV,
and that's just the EDV,
the end diastolic volume,
minus the end systolic volume.
which is the amount of blood left in the ventricle after contraction.
Right.
Now, there's this really cool diagram called the Wiggers diagram.
Yeah, it's a graphical representation of all these pressure and volume changes during the cardiac cycle.
I think it's helpful to visualize it.
Absolutely. You can see the aortic pressure, left ventricular pressure, left atrial pressure, and left ventricular volume all plotted against time.
Right. And it's synced up with the ECG.
And the heart sounds.
Yeah. So you can see how everything relates.
It's really neat.
It is.
You can even see the dicrotic notch.
The dicrotic notch.
Yeah, that little dip in the aortic pressure curve when the aortic valve closes.
Oh, right.
And the AC and V waves on the left atrial pressure curve.
Those are like tiny little bumps, right?
Yeah, they represent atrial contraction, ventricular contraction, and atrial filling.
Right.
Pretty amazing.
It is.
And all of this helps us understand things like CVP,
Central venous pressure.
Right. Which reflects right atrial pressure.
And the preload.
And the heart sounds we hear are a direct result of these pressure and valve events.
Right. Like that S3 gallop we talked about.
Yeah, that can indicate increased ventricular volume or compliance, like in heart failure.
And an S4 can mean a stiff ventricle.
Right.
Okay, I think we're ready to go even deeper.
Yeah.
Deeper.
Deeper to the cellular level.
This is the cardiac action potential.
The cardiac action potential.
This is where the electrical activity of the heart originates.
It's all about ions. Right.
It is. Sodium, potassium, calcium, chloride.
Moving in and out of the cells.
Through ion channels.
Right. And the sodium-potassium pump works really hard to maintain those concentration gradients.
Absolutely. So in resting ventricular myocyte, the membrane is more permeable to potassium.
Okay.
Which is more concentrated inside the cell.
Right.
So potassium ions flow out, creating a negative resting membrane potential.
Okay.
Around -90 millivolts.
Okay, and then what happens when the cell gets stimulated?
That's when the action potential kicks in.
The action potential, it has 5 phases.
Numbered 4 through 0.
Weird numbering system.
Oh, right.
But anyway, phase 4 is that resting membrane potential.
Right.
And then phase 0 is rapid depolarization.
When the cell becomes more positive.
Right, and that's caused by a rapid influx of sodium ions through voltage-gated sodium channels.
Right. Then phase 1 is early repolarization.
A brief dip back down.
Yeah.
As those sodium channels close.
And some potassium channels open.
Right. But then comes the plateau phase, phase 2.
The plateau.
Yeah, it's unique to cardiac muscle cells.
What happens during the plateau?
Calcium enters the cell.
Okay.
Through L-type calcium channels.
Right.
And this calcium influx is really important.
Why?
It triggers the release of even more calcium
Okay.
from the sarcoplasmic reticulum.
Right.
And that's what ultimately causes the muscle to contract.
Okay.
Excitation-contraction coupling.
Wow.
Yeah, and this plateau phase also contributes to the refractory period.
The refractory period.
Yeah, that's the time when the cell can't be stimulated again.
Right.
It prevents the heart from going into tetanus.
Which would be bad.
Very bad.
Yeah.
Finally, in phase 3, the calcium channels close.
Okay.
And potassium channels open wide.
Letting potassium rush out?
Right. Repolarizing the cell back to its resting state.
Back to phase 4.
Exactly. Now, pacemaker cells, like in the SA and AV nodes, they have a slightly different action potential.
Right. They're the ones that generate those spontaneous impulses.
Right. So their phase 4 isn't a stable resting potential.
It's not.
No, it's a slow depolarization called the pacemaker potential.
Okay.
And is driven by a few key currents.
Okay.
There's the funny current, or IF.
The funny.
I know, it has a funny name.
So it does.
But it's a slow inward sodium and potassium current.
Okay.
And then there's a decrease in the outward potassium current.
Okay.
And finally, T-type calcium channels open.
T-type.
Yeah, transient.
Okay.
All of that contributes to the gradual depolarization.
Okay.
And the steeper the slope of this depolarization, the faster the heart rate.
Makes sense. So what happens when they reach threshold?
Then they fire.
Okay.
And the depolarization phase 0 is mainly due to calcium influx.
Okay.
Through L-type calcium channels.
Yeah.
So the upstroke is a bit slower than in ventricular myocytes.
Okay.
And then phase 3 is repolarization, same as in the myocytes.
With potassium flowing out.
Right.
So pacemaker cells don't have that distinct phase 1.
Right.
Or the long plateau of phase 2.
Exactly.
And of course, just like with anything else in the heart, things can go wrong with these ion channels.
Oh, yeah.
Leading to arrhythmias.
Right.
Like medications can block potassium channels, leading to a prolonged QT interval.
Which can cause torsades de pointe.
Yeah, a nasty arrhythmia.
It is.
And in ischemia, the lack of oxygen can mess up the sodium-potassium pump,
And open KATP channels.
leading to more arrhythmias.
It's all interconnected
It is. Okay, I think we have a pretty solid foundation now.
in cardiac anatomy and physiology.
Yeah.
So, are we ready to talk about ischemic heart disease?
Let's do it. IHD.
A big one.
A huge one.
Coronary artery disease. CAD.
It all comes down to an imbalance between oxygen supply and demand.
Right. The heart muscle needs oxygen.
And if the coronary arteries can't deliver enough, you get ischemia.
And that can lead to angina or even a heart attack.
Yeah, a myocardial infarction.
And the main culprit is atherosclerosis.
Atherosclerosis. It's a chronic inflammatory disease that affects the arteries.
It's a slow process that starts with damage to the endothelium.
The inner lining of the artery.
Right. And that damage can be caused by a lot of things.
Like high blood pressure, smoking, high cholesterol.
Diabetes.
Yeah. And once the endothelium is damaged, LDL cholesterol can sneak in.
the bad cholesterol,
Yeah, and it gets oxidized.
which attracts macrophages.
Those are immune cells.
Right. And they gobble up the oxidized LDL, turning into foam cells.
Foam cells, right? And those foam cells accumulate, forming fatty streaks.
The first visible signs of atherosclerosis.
And then smooth muscle cells from the middle layer of the artery, they migrate in.
And they start to proliferate,
And lay down a fibrous cap over that lipid core.
forming a plaque.
A plaque.
And these plaques grow over time, narrowing the artery.
Causing stenosis.
Right. And if the stenosis is severe enough, it can limit blood flow.
Leading to ischemia.
And that's when you start to get symptoms.
Like stable angina.
Right. Chest pain that comes on with exertion.
And is relieved by rest or nitroglycerin.
Right.
But it's not just the slow narrowing that's a problem.
No, these plaques can also become unstable.
Unstable.
Yeah, the fibrous cap can rupture.
Exposing the lipid core.
Right. And that triggers clot formation.
A thrombus.
Right.
And that can partially or completely block the artery.
Leading to unstable angina and stemio, or STEMI.
Right, the acute coronary syndromes.
And while atherosclerosis is the most common cause of ischemia, it's not the only one,
Right. There's coronary artery spasm.
like in Prinzmetal's angina.
Yeah. And then there are emboli
Blood clots that travel from somewhere else.
and arteritis.
Inflammation of the arteries.
And sometimes it's a supply-demand mismatch.
Like in severe anemia or tachycardia.
Yeah. And in women, we can see ischemia with non-obstructive coronary arteries, or INOCA.
Right. Often due to microvascular dysfunction or coronary vasospasm.
Right. Okay, so now let's talk about what happens at the cellular level when you have ischemia.
Okay.
So basically, the heart muscle cells, they need oxygen to produce ATP.
Right. That's their energy source,
And when there's not enough oxygen, they switch to anaerobic metabolism.
which is much less efficient,
Yeah. And it produces lactic acid.
leading to acidosis,
Right. And all of that messes with the ion pumps in the cell membrane.
like the sodium-potassium pump.
Yeah.
And that can lead to an accumulation of sodium and calcium inside the cell.
Right. And that messes with the electrical activity of the cell.
They're going to get more prone to arrhythmias.
Right. And it also affects the contractile proteins.
Actin and myosin.
Yeah. So the heart muscle doesn't contract as well.
We call that myocardial stunning.
And if ischemia continues, you start to see structural changes in the cells.
Right.
Like glycogen depletion, mitochondrial swelling.
The cells are really struggling.
They are.
And if the blood flow isn't restored quickly enough, they start to die.
Necrosis.
Right.
And even when blood flow is restored, you can get reperfusion injury.
Yep, that's damage caused by the sudden influx of oxygen.
Right. And the inflammatory response.
It's a double whammy.
It is.
So after a heart attack, the body tries to heal the damaged tissue.
By forming a scar.
Right.
Yeah.
But scar tissue doesn't contract like healthy heart muscle,
Right. And it can also mess with the electrical conduction of the heart.
leading to more arrhythmias.
And the heart doesn't just sit there after an MI.
No, it undergoes remodeling.
Remodeling.
Yeah, changes its size and shape.
Trying to compensate for the damage.
Right. But that remodeling can actually be harmful in the long run,
It can.
leading to heart failure.
Right. Okay, let's talk about stable angina.
Okay, so stable angina is like a warning sign.
Oh, warning sign.
Yeah, it's telling you that the heart isn't getting enough oxygen.
With exertion.
Right. And it's usually caused by a fixed plaque in a coronary artery.
Right, so the artery can't dilate enough to meet the increased demand.
Exactly.
So the classic presentation is chest pain or pressure that comes on with exertion and is relieved by rest or nitroglycerin.
Right. It's predictable.
Predictable, yeah.
But some people might have atypical symptoms.
Yeah, like shortness of breath or fatigue.
Especially women.